Well, I'm Chris Cannon for Cardiosaurus News, reviewing here the 2013 ACC-AHA guideline for the treatment of cholesterol to reduce atherosclerotic cardiovascular risk in adults. So we have 10 points to remember, and the first of the 10 points is that the 2013 ACC-AHA expert panel included all 16 members of the National Heart, Lung, and Blood Institute Adult Treatment Panel 4, or ATP4, that had originally commissioned this document. And so the document reviewed included 23 expert reviewers and representatives of federal agencies. Now, the expert panel recommendations arose from careful consideration of an extensive body of high-quality evidence derived from randomized clinical trials, systematic reviews, and meta-analyses of randomized clinical trials. So key point 2 is that through this rigorous process, 4 groups of individuals were identified for whom there's an extensive body of randomized clinical trial evidence demonstrating a reduction in atherosclerotic cardiovascular disease events with a good margin of safety from statin therapy. And so these 4 statin benefit groups are: 1, individuals with clinical atherosclerotic cardiovascular disease without New York Heart Class 2 through 4 heart failure or receiving hemodialysis. 2, individuals with primary elevations of LDL cholesterol above 190. 3, individuals aged 40 to 75 with diabetes and an LDL above 70 and below 190 without cardiovascular disease, so primary prevention. And individuals, again, without atherosclerotic cardiovascular disease or diabetes, aged 40 to 75 with an LDL between 70 and 189, who have an estimated 10-year atherosclerotic risk of 7.5% or higher. Point 3 is on that latter group, those without documented disease or diabetes, age 40 to 75, with atherosclerotic risk of 7.5 or higher. This group is identified by using the new pooled cohort equations for atherosclerotic risk prediction as developed by the risk assessment work group. And this is fatal or non-fatal MI and fatal or non-fatal stroke, the latter being a new addition to the overall risk assessment. 4, lifestyle modification, i.e. adhering to a heart-healthy diet, regular exercise habits, avoiding tobacco products, and maintenance of a healthy weight, remain a critical component of health promotion and atherosclerotic cardiovascular disease risk prevention, both prior to and in concert with use of cholesterol-lowering therapies. 5, there is no evidence to support continued use of specific LDL and/or non-HDL cholesterol treatment targets. The appropriate intensity of statin therapy should be used to reduce risk in those most likely to benefit. Non-statin therapies, whether alone or in addition to statin, do not provide acceptable atherosclerotic risk reduction benefits compared to their potential adverse effects for routine prevention of atherosclerotic cardiovascular disease. So number 6, this guideline recommends the use of the new pooled cohort equations to estimate 10-year atherosclerotic cardiovascular risk in both white and black men and women. By more accurately identifying higher risk individuals for statin therapy, the guideline focuses statin therapy on those most likely to benefit. It also indicates elsewhere in this guideline, based on trial data, those high-risk groups that may not benefit. Number 7, no recommendations are made to inform treatment decisions in selected individuals who are not included in the 4 statin groups. And so these individuals are those who have a 10-year risk that's below 7.5%, or when the decision is unclear. Other factors including family history of premature atherosclerotic disease, LDL above 160, high sensitivity CRP greater than or equal to 2 milligrams per deciliter, calcium score greater than or equal to 300, Agatston units or greater than the 75th percentile for age, sex, ethnicity, and ankle brachial index less than 0.9, or elevated lifetime risk of atherosclerotic disease may be used to enhance the treatment decision making. 8. High-intensity statin therapy is defined as a daily dose that lowers LDL by greater than or equal to 50%, and moderate intensity lowers LDL by 30 to less than 50%. All patients with atherosclerotic disease who are less than or equal to age 75, as well as patients greater than 75, should receive high-intensity statin therapy. Or if not a candidate for high-intensity therapy, they should receive moderate-intensity statin therapy. 9. For those with an LDL greater than or equal to 190, they should receive high-intensity or moderate-intensity statin therapy if not a candidate for high-intensity therapy. Additional of other cholesterol-lowering agents can be considered further to lower LDL. Diabetics with a 10-year atherosclerotic risk of greater than or equal to 7.5 should receive high-intensity statins, and if it's less than 7.5%, moderate-intensity statin therapy. Individuals who are age 40 to 75 with a greater than or equal to 7.5% 10-year risk should receive moderate to high-intensity statin therapy. And finally, key point 10, the following are no longer considered appropriate strategies. That is, treat to target, lower is best, treat to the level of atherosclerotic risk based on lifetime atherosclerotic risk. The guidelines provided no recommendations for initiating or discontinuing statin in New York Heart Class 2 to 4 ischemic heart failure patients or those on maintenance hemodialysis. So some comments that I'll offer. This is obviously a big paradigm shift that has a major focus on matching the guideline recommendations to areas where there are direct evidence supporting it. And as such, it's a little bit more specific in these 4 statin benefit groups than other guidelines that use a little bit more clinical judgment as to risk. There'll be lots of debate. What about the elderly, and should everyone get intensive statin therapy if at their higher risk? And what about targets? Are we throwing them out entirely? I think this is a very good evidence-based guideline and should generate some excellent discussion on how to optimally manage patients. The theme is to advance intensity of statin therapy, which has been seen in many trials to be of benefit. And we, of course, have to balance that against other potential risks and side effects as they emerge. And so this will likely be the beginning of a very rejuvenated discussion of how to best manage cholesterol. So for CardioSource News, I'm Chris Cannon.